cancer is on the increase globally, but the highest increase is actually happening in low and middle income countries.
Dr. Miriam Mutebi is a breast surgical oncologist at the Aga Khan University in Nairobi, Kenya. She is also a health systems researcher transforming cancer care for women in Africa through her work to understand and mitigate barriers to diagnosis and treatment.
For patients, it's the small things. It's just taking another 1 or 2 minutes to say, hey, your kids they had that recital. How did that go? They're like, oh, you remember.
She co-founded the Pan-African Women's Association of Surgeons and is an advocate for female surgeons and gender equity in global oncology.
Surgery had been perceived as a male profession. I found when I was in training, I was pretty much the only woman there.
Welcome to Stanford Department of Medicine's Inside Look at the Future of Medicine. Well, Miriam, welcome to Stanford.
Thank you. Happy to be here.
Yeah, we're so happy to have you, and I'm really looking forward to our conversation. And I wanted just to start with you. And you have such a remarkable story, personal story. Let's take us back to the beginning, first of all. You grew up in Kenya.
Yes.
Tell us about what attracted you. Tell me about that upbringing and what attracted you to medicine and then ultimately to surgery.
Okay. I'm glad you're kind of asking about, backstories and origin stories. I'd probably start off, we always have a running joke that whenever somebody asks you that question, your opening statement is, some Cook's song, I was born by the river.
Yeah, that's good.
And kind of build up from there.
Feel free to sing that song if you want.
No, but really, I think sort of growing up in Kenya, and I think you're wondering how I sort of wandered into surgery.
How did you wander into surgery?
It's a series of, I think it's one of those experiences that kind of influence the next step, so to speak. Now, I grew up in an area called Langata, which is right next to an airstrip.
Okay.
And what used to happen was that we used to have a flying doctors, African Medical Relief Services, very big for a while, still quite big, but definitely branched out into many different directions. But growing up, it was kind of seeing, near the airstrip, kind of seeing planes overhead and stuff. And so I was like, I'm going to be a flying doctor.
Okay.
Right? Yeah. But of course, what happens is, in high school, you kind of have a sense of everything. We get into college directly, into like specialty training. And so I think at the end of high school, I had 5 different things I wanted to do. I wanted to do medicine. I wanted to do law. I wanted to write. I'm a really bad poet. And then I wanted to, what was the other thing? Pharmacy. And also, I think there was architecture. So I ended up doing and all incredible interest. So what I did was I took a bit of time, spent some time sort of shadowing each of those, and then kind of got it down to medicine. So I actually went and worked, with a pharmacy, law firm, went and worked for a publishing house, and then kind of got it down to 2 things, which was medicine and writing. And so I go to my dad and I say, Dad, I have this choice. I want to do medicine, but I want to write. And he said, well, if you do medicine, you can write.
Yes, right. Indeed.
And so I'm like, okay, medicine. And then again, just because each experience is I think influences a subsequent one. When I was doing my medicine rotation, which was mid 2000s and stuff, what happened was that we were kind of maybe at the tail end of the HIV epidemic. And at that time, unfortunately, there was still a lot of stigma around HIV and not as much access to antiretroviral drugs, which is a very different story now. And so when we were doing our rotations at the time, you'd find that you'd go into the medical wards, and unfortunately, there were people who had acute medical conditions, pneumonias and whatever, but then sort of going downstream, you'd find that quite a number of patients who'd been abandoned by their relatives because they don't have access to medications, which is a very different, given the advances with PEPFAR and producing access to this, a very different story now. But that was what we were seeing, and there was a sense of, how can I make a difference? And then we would go like 3 floors down, and that was to the surgical ward. And somebody comes in, they hit, you take them to theater, you make them better, they go home, and I'm like, I am so doing this. And then so I'm like, okay, then we got into surgery. And then looking at surgery, we end up having lots of rotations. And as a surgical resident, we're always guilty of what we call end of rotationitis, meaning you kind of love the rotation that you're doing. And so, wanted to do urology, wanted to do orthopedics, so many things. And then I had to do I did a breast rotation, and I suddenly realized that the patients that they were describing in the textbook had nothing at all to do with the patients I was seeing.
What you were seeing.
The textbooks were saying, breast cancer is a disease of, the 6th and 7th decade, meaning affecting you in your 60s and 70s. And typically older women who haven't had any children, who haven't breastfed, all of which are supposed to be traditionally protective factors for women. And I'm sitting in clinic, I'm seeing my patients are in their 30s and 40s, sometimes even in their 20s, right? And they've had multiple children, breastfed, haven't maybe used and none of those risk factors actually apply. And so I'm like, what is going on? Right. So that's how I kind of wandered into breast surgery. But then beyond that.
But it just does, it wasn't that common at the time, I think, for women to be training in surgery in that arena. You were one of the earliest ones?
Yeah. I think just in terms of, for the longest time, I think surgery had been perceived as a male profession. And so what I found when I was in training, I was pretty much the only woman there. But which is to say, we've certainly made considerable strides in the last 10 years. That's increased exponentially. But at the time, it wasn't something that you saw commonly. And I think it was more of, I would say, the lack of representation. So because nobody had seen it, nobody wanted to do it. And so I think one of my sort of issues or my traits, which is a good thing or a bad thing, is my stubbornness.
That's an important trait for anyone doing medicine or surgery.
And so, as soon as somebody says you can't do it, I'm like, no, I'm going to show you. Watch me doing it. But I think it was one of those things where opportunity meets, maybe at the cusp of where we're starting to be a little more open and embracive of different specialities. So I think I sort of ended up going off in that direction. And certainly...
You mentioned in one of the pieces that your dad had given you some advice early on that had kind of stuck with you through your career. Can you talk a little bit about that?
I'm trying to think about that. He's given me lots of advice.
Most fathers are quite opinionated. Anything in particular come to mind?
Well, I don't know if it's career related, but my dad always says, don't suspend the joy. The two things that he actually says are, one, the more common things are don't suspend the joy, and two, it costs you nothing to be kind. Right? And I think that's kind of been the anchor in terms of what is it that you're bringing to a patient interaction, what is it you're, trying to achieve. So it's really looking beyond the disease, but really drilling down to that patient-centered approach. And sometimes, we have, this thing of I have to see a lot of patients. I find that for patients, it's the small things. It's just taking another 1 or 2 minutes to say, hey, your kids were having their birthday party or they had that recital. How did that go? They're like, oh, you remember. And like it doesn't cost you anything, but it takes a level of engagement and interaction to a different level. And I think that's incredibly important, especially for patients who are walking a journey in which we're helping to support, like our breast cancer ladies. They start off with us, they have to go to radiology, they have to go through radiotherapy, chemotherapy, so really making sure that we're present and there really makes a difference. We have a national public holiday, Mashujaa Day, which is really about celebrating our heroes. And one of my patients called me up. She's like, "Doc, you're my hero." And I'm like, "No, man." I mean, it's incredibly humbling, but you're like, "No, you're the real hero. You're the one, going through this, and your grace and resilience are really just, what keeps, inspires us to keep moving and stuff." So I think those are kind of my anchoring maxims, and I hope that translate not just to my professional life, but in my interactions with colleagues and families, and also in terms of sort of mentoring the next generation, because part of what when I started off as the only female in surgery, the idea was that I'm definitely the first, but I'm not going to be the last, right? So how do we create a conducive environment in which we can support women? Because sort of talking of the grassroots, and to people on the ground, it wasn't a lack of interest. It was people would maybe come in, find a hostile environment and leave, or get frustrated. So we said, how do we create a space for continental women across Africa where women feel supported and really get opportunities around transformative leadership? Because from a health workforce perspective, there's very few healthcare providers. Not as many healthcare providers. So the few tend to find themselves in leadership positions, whether it's in your clinic, in your hospital, in your institution, or even at government or institutional level. So how do we give these women the skill sets that they can carry forward to all their different aspects of leadership and engaging with communities, and really having that community footprint is what the Pan-African Women's Association of Surgeons is all about.
This is the organization that you put together, and I think that role model element is so important. And
exactly.
I think, as you say, take the first few, it's hard, and when there's a small number. But as each new person comes in and adopts a position and is there as a role model for the next generation, it spreads.
Exactly. You get to a critical mass, and
critical mass is where you're aiming from. And it takes flight. Well, we'll come back to flying. But you just gave a wonderful Grand Rounds presentation here at Stanford on your recent work and these organizations that you've been leading. But some of the things that really struck me were the data you showed on the differing presentations, let's say in Europe and the US. We're so used to all the data. You showed a very striking statistic of where the amount of resource that is put towards cancer research is spent versus where the cancer is in the world. I wonder if you could speak a little about that, and then also the differing presentations. I remember that slide. Tell us a little about how those facts, maybe tell us the facts and give us a sense of how they are driving what you're trying to do.
Sure. I think one of the things that I shared was in terms of the disease burden. And the first is that cancer is on the increase globally, but the highest increase is actually happening in low and middle, what we define as low and middle income countries. And looking at the cancer deaths around that, we noticed that 70% of the global cancer deaths are occurring in these settings. But then looking at that versus the resources that are actually spent not just in research, but even in care delivery, it only provides about 5% of the global expenditure, which really should make all of us collectively sit down and thinking like, that doesn't seem particularly
and
right.
Just be clear, that ratio is 70% versus 5.
Exactly. And so it's really an opportunity for us to think about how can we do better, and what are some of the opportunities for perhaps as a community of practice, not just locally but globally, really trying to start to shift this is one of the thrusts. And then in terms of looking at the diagnosis of I'm just going to use breast cancer as an example, because, for instance, for our women, you find that in many parts of Africa, quite a number of our patients are diagnosed with advanced disease and often do not complete their care. Now, we're even moving away from, sort of saying, the language matters, because sometimes when we say delayed presentation, it almost gives the implication or that the patient has, it's the burden is exactly. But what we find is that one, patients are having to pay out of pocket for them to access care. So that's already a struggle that they're really, trying to get enough money to, get the next paycheck perhaps, or sometimes you don't even have a paycheck, you're just, living, on odd jobs and stuff to get enough money. And then for women in particular, there because, again, they're the highest growing economy, but largely blue collar. Yeah. So sometimes they may sometimes have to rely on a partner for support, sometimes even permission in order for them to access care. But then the reason we're sort of switching the narrative the phrasing to delayed presentation is what we realize is in many settings, patients are actually seeing anywhere between 4 to 6 healthcare providers before definitive diagnosis of their cancer is made. So it doesn't mean that the patient's not actually showing up. They're just effectively ping-ponging through the system without necessarily getting the care that they deserve. And then part of the other sort of broader bucket of barriers that we had referenced was really the social cultural barriers. Yeah. One of these is, there's still a lot of stigma around breast cancer, but then also what we call collectivism, which is a term that frames decisions that are made by the community. Now we say in Africa, our community is our strength. We love community, but when it starts to engage on the patient's agency, then it becomes a problem. Now, I'll give you an example. Sometimes when I have a patient, I would give her the surgical options and say, this is a small cancer, we could just do a lumpectomy and remove that area, or, the alternative is a mastectomy. And sometimes she'll say, I want to take a bit of time, I'll go home, think about it, and, come back with a response. But then, sometimes it comes back with 5 people, and sometimes the family spokesman, and the opening statement is, we have decided, and I'm like, wait, who's we? Who's we? Let's let's take a beat. And it's like, no, we've decided she's going to have a mastectomy or whatever. And sometimes you would sort of gently probe because you've had the discussion with your patient, so you kind of know what she wants, and you're looking at her, but you're like, that's not what you had expressed.
A remarkably different
from what
you're used to.
Exactly. But she would say, well, I want this, but they're the ones paying. And you see, that is a statement that just stuck in my head, because it's not about just giving agency. It's also, how do you provide the financial backing to support those decisions for our women is really the thrust of what we're trying to do as well.
Remarkable. You also talked, I think, very eloquently about cancer fatalism, and it's a remarkable fact that you spoke about in Grand Rounds about how many of the local dialects don't even have a word for cancer.
Absolutely.
Talk to us a little.
Sure. And I think one of the part of the research that we've been doing has been around the language of cancer. And what we found was that in many dialects, and this is important because each country has several dialects. So you might find Kenya, for instance, maybe has about 65 different dialects. I mean, we have a national language is English, Swahili. Other countries like Ethiopia have about 80. So then trying to understand, because there hasn't been a language for cancer or a name for it, then you find some of the names actually have a negative connotation. Some are sort of neutral, like cancer is called saratani, for instance, in Swahili, which just means cancer. It doesn't have any negative connotation. But you'd find in certain communities, you'd find the word for cancer is the thing that kills you, or the wound that doesn't heal. Wow. And so if I'm told I have the wound that doesn't heal, or the thing that would kill me, why would I come to the hospital? But the other critical bit is beyond what the community's understanding is of the cancer. What is our communication of those terms and medical terms in to our populations? Because we were looked at the part of the work we also did as part of this research was trying to understand, what are you telling patients?
Yeah.
And so what you would typically find, Ewan, is we would tell you, there you are, for instance, as a woman, there you are minding your own business.
Yeah.
Come into the hospital and we will press your breast and you will get a picture.
Yeah.
And then if there's a problem, we will chop it off. When we're done chopping it off, we will burn the area and we may give you a little poison in your veins, and you're wondering why you don't have a queue of people, lining up for treatment.
Sound very appealing.
Exactly. And so it's really being cognizant of what is, one, the patient's understanding, what are we communicating, and how are we sort of ensuring that we have the right language, the right outlook in terms of really infusing hope and positivity in terms of getting their treatments and when it was in a timely manner.
Yeah, that's remarkable. Yeah. I wish we had a bit more time to talk. I feel like I could talk to you for hours, but I can't let you go without talking about your hobby.
Okay.
Also, you talked about...
I have several.
Well, that's true. I've heard of several, but the one I'm particularly excited about as an aviation enthusiast is your flying. You said you were inspired into medicine by seeing the flying doctors, and I understand you're learning to be a pilot.
Yes. So it's one of those things where, you kind of go to your bucket list at 10, 5, 10, 15, 20, and you're like, okay, Miriam, we need to do something about this. It can't be top of your bucket list
forever.
Eventually, all the time.
Right.
But the thinking behind it, to be completely honest, was how do I kind of, we do a lot of outreach in areas where sometimes you're taking a 12-hour journey or whatever. So it was in my mind, can I get there faster?
Yeah.
Is there a way of disseminating some of these
cars.
Exactly. Getting to these centers and these sites much quicker. And so what I've been doing is ground school is completely painful, honestly.
It's the physics of flight.
Exactly. And I've heard that the ground school in Kenya is pretty intense. Okay. Everybody else is international is like, if you can do ground school in Kenya, you're good for anywhere. So it's a lot of geography, map reading, and the best bit about
navigation.
Exactly. The best bit about it is the actual flying, which is incredible. And
do you fly? What do you fly?
It's a Cessna, but a small one, a 152.
152.
The first time was a very different experience, where you almost feel like you're about to get reacquainted with your lunch, kind of thing, with the bumps and everything. But it's been a good journey.
Do you notice parallels between learning to fly, learning to be a surgeon?
Absolutely, because I mean, part of the checklist manifesto, I think, by Atul Gawande, and I think really has its in making sure your checks and balances are in, and checking and rechecking. So there are those parallels. You do need your team. You do need constant communication within the tower. The same with when we're considering the anesthetist, the tower of wisdom.
There you are. Tower of wisdom. Anesthesiologist, the tower of wisdom. I think no argument here for me on that.
Exactly. And so it's really that good communication, teamwork, and attention to detail, and sort of going through the route that actually makes, and you're taking flight. It's enjoyable, and that's what theatre and surgery is. So,
I think that's wonderful, and an amazing place for us to finish. Well, Miriam, thank you so much for joining us today.
Thank you for having me.
It's been a really great conversation.
Thank you so much. Looking forward. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.